Welcome to the debate. Today, we're tackling a really central question in managing stroke risk. What's the best long-term strategy for patients who've had symptoms from carotid stenosis specifically? Blockages between 50 and 99%. Now, for a long time, the default has been intervention, carotid endarterectomy, CEA, or stenting, CAS, on top of medical therapy. But medicine's evolved, hasn't it? Best medical treatment, or BMT, is, well, dramatically better now. So we have to ask, does adding that revascularization procedure still give a necessary significant long-term edge in preventing stroke and death compared to just optimizing modern BMT alone?
That really is the core issue, isn't it? With BMT becoming so effective, we absolutely have to re-examine those older assumptions.
Right. And my position is grounded in the pooled evidence we have, looking long-term. I think that evidence, especially when you drill down into specific high-risk patient groups, still shows a gap, a clinically meaningful one, that argues for needing revascularization to really minimize that long-term stroke danger.
See, I look at it differently. Yes, there are numerical trends. I see that. But the studies themselves have significant limitations. Biases, they're quite garried methodologically. And because of that, I'd argue it's actually impossible to definitively say intervention is superior. So modern BMT, when it's truly pushed to its optimum, has to be considered an equally valid first-line approach for, well, probably many of these patients, and maybe even safer for some.
Okay, let's dig into that, starting with the main pooled outcomes from the systematic review. Looking long-term, the data does paint a picture favoring intervention. The pooled risk of a later stroke for patients on BMT alone was reported as 6.96%. Compare that to 4.51% for the group that got revascularization. And if you look at the combined risk, stroke or death, it was 8.91% for BMT versus 6.56% for revascularization. Now that's, over a 2 percentage point difference in absolute stroke risk over time? For something as devastating as a stroke, a 2-point difference isn't just statistical noise. It warrants real clinical caution and, for me, reinforces the standard practice: intervention plus BMT.
I absolutely acknowledge those numbers. And yes, they show a tendency, but we need to be precise with the language of the evidence here. The review authors themselves, despite that trend, explicitly stated they couldn't establish statistical superiority for one treatment over the other. That lack of definitive proof is, well, central to my point about BMT's viability. Plus, we can't ignore the time lag. The big trials that set this standard of care, NACIT, ECS, they were run, 30 years ago? The BMT back then just wasn't the same caliber as what we use routinely today.
That's a fair point about the age of the data. Could you elaborate maybe on just how much medical management has changed?
Oh, absolutely. It's not just minor tinkering. We're talking about a complete shift. Today's BMT includes high-intensity statins. That's huge. They stabilize the plaque, reduce inflammation. It changes the actual physiology of the disease at the plaque level. Back when NACIT and ECST were running, statins weren't standard practice at all. Add to that better antiplatelets, much tighter blood pressure control, stricter lipid targets. All this has slashed the baseline stroke risk so dramatically that the extra benefit you get from physically removing the plaque is, well, it's just far smaller today than it was in the 90s. It fundamentally shifts the risk-benefit calculation away from just defaulting to intervention.
Okay, I understand that argument, focusing on the overall lower baseline risk. Now, but let me pivot slightly and focus on the patients who, despite our best medical efforts today, remain at exceptionally high risk. We really need to look closely at that subgroup analysis on carotid near-occlusion, CNO, that's the 95 to 99% stenosis group. Because for that specific very high-risk anatomy, the review shows a drastically different picture, one where BMT alone seems, insufficient.
Right. The CNO group. Tell me more about that data, because CNO has always been a bit of a paradox in this whole discussion, hasn't it?
It really has. But this pooled analysis found that for patients with CNO, the long-term stroke risk, if they were managed with BMT alone, was frankly staggering, 13.46%. Now compare that to the risk in the same type of patients who had CEA, just 2.80%. That's nearly a five-fold difference in absolute risk. This isn't just a trend. It strongly suggests that for these really tight, maybe unstable lesions, revascularization is just unequivocally safer. It seems essential for cutting down that extreme long-term risk. The mechanical fix seems critical there.
That's definitely a striking number from this recent review for CNO. But how does that square with current major European guidelines? It is a paradox. The ESVS guidelines, for instance, often recommend BMT first for CNO patients, holding surgery back for those who have symptoms despite BMT.
Huh. Why would they do that, given the numbers we just talked about? That seems counterintuitive.
Well, it goes back to those older seminal trials again. Post hoc analyses of NASIC and ECST actually suggested something different, that patients with CNO, that very high-grade stenosis, might have had a lower risk of stroke recurring compared to those with slightly less severe stenosis, say in the 80 to 90% range. The old thinking, the low flow idea, was that once the artery gets that close to closing off, the blood flow drops so much that the source of potential clots kind of dries up, making it paradoxically safer than a moderate stenosis that still has a turbulent, high flow capable of dislodging debris.
So the new CNO data you're citing, that 13.46% risk on BMT, directly challenges that long-held sort of foundational hypothesis from decades ago.
It does challenge it, yes. But we have to be critical about the data underpinning this new challenge. That CNO data in the recent review, while it looks dramatic, is actually based on a very small number of patients, pulled from only 2 studies. And remember the issues with those original trials. High rates of crossover, where patients assigned to medical therapy ended up getting surgery anyway because they weren't doing well. Plus, the limitations of doing an intention to treat analysis in that context. It might have accidentally made the BMT group look riskier in the CNO subgroup than it really was. Those original studies just weren't designed to test CNO specifically.
I take your point on the methodological weaknesses. Those are always challenges when you're trying to synthesize a clear picture from different studies run at different times with different protocols.
And that leads right into my central concern, the questionable quality of the overall data we're relying on. This systematic review only found 5 studies they could even include in the analysis, and all of them were rated as only moderate quality, methodologically speaking, using the minor score. We just don't have enough high-quality, randomized trial data directly comparing modern, fully optimized BMT alone versus BMT plus revascularization. So we're left leaning on studies that are frankly prone to significant selection bias.
Can you give a concrete example of that bias you're concerned about?
Sure. Take the Rodrigues et al. Study. It reported a statistically higher risk of death in the BMT group, 8% versus about 1.5% for the CAA group. But how was that BMT group put together? It explicitly included patients who had already declined surgery. Now, those aren't equivalent groups to start with. Patients who turn down major surgery might have more underlying health problems, different attitudes towards risk, maybe different levels of adherence, factors that could independently lead to worse outcomes, making the BMT arm look artificially risky. It's not a clean comparison. And the fact that it's so hard to recruit patients into BMT-only arms of trials, look at the struggles SPACE 2 had, means we're systematically missing that pure, high-quality data on what optimized BMT alone can really achieve.
Okay, I acknowledge the recruitment challenges and the point about potential selection bias is certainly valid. But let's step back from just the stroke and death statistics for a moment and think clinically. What about TIAs, the rates of recurrent transient ischemic attacks? What do those tell us about the stability BMT provides long-term?
That is an important clinical endpoint, yes.
While the pooled analysis showed a TIA risk of 17.14% for the BMT group, that's compared to only 5.72% for the revascularization group. Now, a TIA isn't a full stroke, obviously, but it's a huge red flag, isn't it? It signals ongoing clot risk, sustained vascular instability. That nearly 12-point difference in TIA recurrence suggests that BMT alone, even if it's perfectly optimized, just doesn't adequately deal with the physical source of microclots long-term in quite a few patients. Revascularization offers a mechanical solution to what is, fundamentally, a mechanical problem at the plaque level.
Okay, but are those TIA figures properly adjusted for things like medication adherence in those specific studies? Is that really an indictment of BMT as a strategy, or is it perhaps a reflection of how BMT was implemented or adhered to in those often older study populations? Intervention fixes the stenosis right there, sure. But BMT is meant to treat the whole system. If BMT seems to be failing based on TIA rates in those studies, maybe it's a failure of doing BMT perfectly, not a failure of the concept itself.
Adherence is always a potential confounder, I agree. But that very high TIA risk still makes me think the mechanical source of the emboli is just too active in some cases for medication alone to consistently suppress it. And this brings us to that critical early period, the time right after the initial symptom. Look at the Rodrigues study again, the one we discussed regarding bias. It also showed that the risk of stroke within the first year was significantly higher in the BMT patients, 14% versus just 1.5% for CEA. That points to a really crucial, immediate window where BMT alone might not be enough protection, where you need the rapid stabilization that intervention provides.
You're highlighting the potential short-term benefit of intervening quickly, but that benefit absolutely comes with an upfront cost, a guaranteed risk. We're essentially accepting a definite short-term increase in risk from the procedure itself, stroke, MI, even death, hoping for a larger payoff in protection years down the line. That initial procedural risk is something BMT completely avoids.
But that risk is generally considered acceptable because of the expected long-term gain, right?
Exactly. It's a trade-off, and one we need to weigh very carefully, especially now. Think about the interim results from the ECST2 trial, which is ongoing. In the first few months, right after the procedure, the group that got revascularized actually had a higher rate of the combined outcome stroke, heart attack, or peri-procedural death. They paid that upfront price. Now, thankfully, the outcomes did seem to converge by the 2-year mark around 10% in both groups, 10.0% for revascularization versus 10.3% for BMT. But the fact that BMT got to basically the same place at 2 years without putting patients through that initial high-risk period, that's very significant. And we also have other data points, like a retrospective analysis by Holbenu et al., that actually found a statistically lower risk of stroke and death combined at 1 year for the BMT group, 4.4% versus 7.6% for revascularization. It suggests that really well-managed BMT can be the safer option, both right away and in the shorter term, at least in some contexts.
This whole discussion really underscores the tension, doesn't it, between how far medical therapy has come and the enduring logic of fixing a mechanical problem mechanically. I still believe that while modern BMT has undoubtedly improved outcomes across the board, the overall evidence we have, when pooled together, shows a persistent, measurable trend favoring intervention. And critically, for those patients with the highest risk anatomy, like CNR, the sheer size of the stroke risk reduction, bringing it down from nearly 14% to under 3%, that's just too large to ignore based only on methodological concerns. For me, revascularization has to remain a key part of the strategy for maximum long-term protection in symptomatic patients.
And I remain convinced that we can't just default to the old ways when BMT is now achieving outcomes so close to equivalence, and it does so while sidestepping that immediate danger of the procedure itself. The evidence base we have right now is simply too limited. It relies too heavily on moderate quality studies, small subgroups, and comparisons that aren't truly randomized to definitively say intervention should always be the default over optimized BMT. That risk-benefit balance needs constant reevaluation. And honestly, we desperately need the final long-term results, like the 5-year data from ECST2, to really get a clear picture of whether modern BMT alone can provide durable long-term management for most of these patients.
We certainly can agree on the need for better, more definitive data. Future trials absolutely must include dedicated arms that use today's best practices for medical therapy, so we can finally get an accurate read on long-term event rates in a truly contemporary, controlled comparison.
Agreed, and there's certainly more complexity here to unpack, especially as medical therapies continue to evolve even further.